Welcome everyone to today's webinar, Operationalizing a Large Da Vinci System Fleet, From One Robot to Many. I am Christelle Kazaka with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions that you have throughout the webinar by typing them into the Q&A box that you see on your screen. If we do not get to your question today, we'll be sure to follow up with you via email. We are looking forward to hearing your questions. This webinar is hosted by Intuitive. It is now my pleasure to introduce you to Frank Casillo, Director of System-Wide Robotics for Northwell Health in New York. Frank, thank you and welcome.
My name is Frank Casillo. I'm the Administrative Lead overseeing the Robotics Program in Northwell Health. And I'm really excited to be here today to talk about our program and discuss with you how we were able to operationalize a large system fleet. I think everyone participating in this discussion can remember a time when the robotic modality was met with cynicism within their organization. You probably heard there is no quality outcomes benefit or it is too expensive. And to a certain extent, this was also the same in Northwell Health. In 2016, our executive leaders decided to align our executive, clinical, and operational arms to form a robotics committee. And the messaging at the time was very clear. They would continue to invest in the program if we were able to first demonstrate superior quality outcomes, excellent patient care, and standardization of care delivery. Now, at that time, I was asked to take the administrative lead for this program. And needless to say, over the last 4 years, I've learned a lot. I've had the time to reflect upon our incredible journey, and I'm here today to discuss how we were able to nearly double our program's volume, how we added 14 incremental systems while simultaneously upgrading 5 existing SI robots, now bringing our current fleet to 26 total robots. How we started 4 de novo programs. How we were able to reduce variability through standardization. And most importantly, how we were able to demonstrate superior quality outcomes and patient experience. So who we are. Northwell Health is the largest private employer in New York State, as well as healthcare provider. We have 23 hospitals and over 800 ambulatory facilities. We're comprised of over 74,000 employees, 4,500 of which are employed physicians, and we have around 1,900 residents and fellows. And as you can see, we're in a pretty dense market, saturated with a lot of competition. Now, bringing us to the robotics program. I mentioned before that we were to align our executive, clinical, and operational arms to form a committee. And we've done that. The committee is led by Mark Salazzo and David Battinelli as our executive committee chairman. From the system clinical leadership standpoint, from every one of our institutions, we have surgeon representation. Now, the thought process behind that was these local leaders would be able to disseminate the information learned as part of the efforts from this committee and bring that back to the local level. And we also have participation from our administration. Myself, I have a clinical counterpart that is instrumental in implementing a lot of the process improvement changes within our ORs. We have representation from marketing, from procurement, from system perioperative services. Now, when we came together, the structure was not necessarily set. We had to determine what I like to call our pillars for success. And we really dedicated our efforts to the following 4 domains. So first being credentialing, quality, operations, and education. Now, from there, we've dovetailed into specific subcommittees that are dedicated to working on these pillars. They bring that information back to the Minimally Invasive and System Robotic Committee for further review and implementation on a system level. Now, I mentioned that we aligned our executive, clinical, and operational arms to come up with this committee, but one vital component to this committee has been our collaboration and partnership with Intuitive Surgical. And through our strategic partnership, we realized that a lot of our goals and our visions align. We wanted a commitment to shift open procedures to minimally invasive and robotic. We wanted to leverage system best practices. We wanted to provide education and training to our surgeons and staff. We wanted the care that you received, regardless of what robotic facility you go to, be the same. So here's a little bit of story of how we've grown over the years. So I mentioned that in 2016, we formalized a committee structure. From there, we've been able to experience over 86% growth from 2016 to 2019. We grew our fleet from 12 systems to 26, and as I mentioned, we standardized the fleet to consist of specifically XI and X systems. And the number of hospitals at Northwell Health offering the robotic modality increased from 8 to 12. You can also see we are multi-specialty with representation from essentially every specialty that can utilize the robotic surgical system. So I'd like to begin with our pillar of credentialing at Northwell Health. Now, although it's not the most exciting topic to discuss, we felt as if it was the most integral to the committee's success. When I began this program, there were 171 surgeons that had the ability to perform robotic surgery, and over 46% of which had not performed a single robotic case in the previous 2 years. Now, our medical staff office and our credentialing department are extremely important in terms of mitigating any type of risks associated with the organization. And what we did not want to do was invest in our robotics program and allow for people that have no real robotic experience to access the technology. We spent a lot of time assessing the existing delineation of privileges for all robotic specialties. From there, we were able to define procedure complexity into tiers, which I felt was very important for our success moving forward. We created a tertiary versus a community strategy. We developed privileging pathways, created proctor summary and case observation forms. We partnered with medical staff to come up with a list of all robotic surgeons that are coming through recredentialing to be able to provide them with snapshots as to how they were performing in terms of their volume thresholds and whether or not they were on target to meet the mandatory 30 cases over 2 years. We established a monthly subcommittee meeting to evaluate initial, extension, cross-credentialing, and recredentialing applicants. Now, for instance, in 2019, we were able to evaluate over 130 applicants. We established clear communication with Intuitive Surgical to minimize the time between training and being granted robotic privileges. As we all know, credentialing is not a 1 to 2 week turnaround. It is rather exhaustive and has a long lead time to be able to do that. And what we were finding was we would have surgeons that would go through training and then try to get robotic privileges. What we've done through our collaboration with Intuitive Surgical is mitigated that time lag between when they're training and when they're receiving their credentials so that they can perform cases essentially immediately after returning from training. Now, I mentioned we took a lot of time looking through our delineation of privileges, and on the screen now is an example of our general surgery delineation of privileges document. So when I began overseeing the program here at Northwell Health, there was simply a one-line item that said robotic surgery. We've turned that into over 20 different procedures and put them into complexity tiers within our DOP. I'd also mentioned we had a community strategy versus a tertiary strategy. So there are some facilities where we do not allow certain types of low complexity procedures to be performed because the thought process was that we want them to focus on our high acuity, high complex cases. Now, conversely, at some of our community-based hospitals, we've eliminated the potential for the applicant to select our high complexity cases, what we consider to be our level 4s. I mentioned how we went through a pathway. This was an area of contention within our organization. There was a lot of back and forth, and it's something that I thought was benign, and we were going to be able to come up with a solution. Took much longer to achieve than I had originally thought. And a lot of what we've done is set volume thresholds, quality thresholds, but we've also put into place remediation options for those individuals that don't necessarily meet the 30 case over 2 year metric that we've established as part of our recredentialing. Now, should an applicant not meet that 30 case threshold, we've put it into tiers. So some tiers would have to go through simulation. Some applicants might have to go through another set of proctoring. And on the right-hand side of the screen, you could see the proctor summary form that we've created here within Northwell Health. It's a one-page document which kept the physicians that were filling it out and completing it very happy. Next, I'll move on to our quality pillar. So our committee's focus was really around using data to drive decision-making. And one of the unique experiences that I encountered when overseeing this program was when I asked how much volume we're doing as an organization, we really couldn't find an accurate answer. And it was essentially for 2 reasons. We have, as I mentioned, 12 different facilities that are utilizing the robotic technology at Northwell Health. Some of those document differently than others. Some would indicate a robotic procedure using an ICD-10 code. Others would indicate it using a CDM code for supplies. So it took time and effort with working with the sites to really understand how their billing processes work to be able to create a comprehensive dashboard. So in addition to now understanding what we're doing in terms of volume, we really wanted to take it to the next level to understand our quality. Now, today we're using financial data to derive quality indicators. And although that's not the ideal way to do it, as many of you are probably aware, non-structured text within our clinical records is not very easy to extract, non-binary. So we've come up with a list of intraoperative or postoperative complications collaboratively with our surgeons to understand when those types of instances occur within our organization. Now, that complication list is comprised of over 470 diagnosis codes. When we started, that list was around 30, and it's since ballooned in the ICD-10 world to be inclusive of over 470. What we also really wanted to do was create an all-modality surgical inpatient dashboard. You know, one of the questions that I had mentioned earlier in the presentation with respect to the program, the robotics program, and the organization perhaps having a cynical view of it is, what is the quality outcomes benefit? Well, in order to be able to speak to that intelligently, we really need to understand how robotic modality compared to, I'm not going to use open, but our laparoscopic volume. And with the success of creating that dashboard, we've had an ability to really gain insight on the impact of the robotic modality as it relates to quality outcomes. We developed standardized clinical pathways as part of an effort to achieve and maintain centers and network of excellence accreditation. In fact, Northwell Health became the first organization in the country in August of 2017 to achieve Network of Excellence designation. And really what that is working collaboratively with the OR teams, the clinical staff, to develop what those standardized clinical pathways should be. We invested heavily in additional quality monitoring technologies such as CSATs. We've put together managed care symposiums using the data that we were able to pull from our all modality dashboard to really have thoughtful conversations with payers regarding the robotic modality. We're heavily invested in research and publications. So I mentioned our system robotic dashboard, and we felt it was very critical to be able to understand our program. And I really have taken a lot of time and very thoughtful to work collaboratively with our surgeons to create this and understand what's important to them. So as you can see, it's the majority of the quality outcomes that everybody here is aware of. It's your readmission rates, it's your length of stay, it's your complications, mortality, CMI, percent cancer, percent ICU, percent transfusion, average cut to close, and average room time. But now we've overlaid that with some additional information with respect to the complications. And also, if your organization is like Northwell Health, we report on all-cause readmissions. And I know that's something that a lot of the surgeons really wanted to move away from, to understand a little more thoughtfully, okay, if I have a patient that's readmitted, is it as a result of something that occurred throughout the course of their surgical intervention, or is it because perhaps they had a slip and fall and hurt their finger? We now have the ability to be able to understand that. One other critical piece to our robotic dashboard is the ability to compare between specialties and understand where there perhaps are outliers within the robotic surgeons that are performing these cases. And we really have the ability to do that and compare not only quality outcomes, but operational indicators such as cut to close, amount of I&A that's used throughout the cases, your average room time. And it's not to be punitive at all. It's really to be able to support these surgeons to become as proficient as they possibly can within the robotic modality. Now, this is just a quick example of our inpatient surgical quality. And really what it is the comparison of all robotic specialties. And what we've been able to do is compare laparoscopic, open, and robotic against one another. And really what we're able to see is there's a significant impact with respect to the robotic modality on a number of the quality outcome measures that we're looking to track. I mentioned before, but it was incredibly important to us as an organization to achieve excellence in robotic surgery. And this was both at the local level through centers of excellence, but also as a system through our network of excellence, to which we achieved that in August of 2017. I mentioned the investment into our intraoperative quality measurement. And to that end, we invested in CSATs, which essentially is a peer-reviewed qualitative and quantitative feedback and scoring that is sent directly to the surgeon. So they have an ability to have a non-biased third party overlook of how they performed all the critical operative steps of each one of their procedures and essentially receive that information in a short amount of time. I talked a little bit about our belief that it was imperative to get in front of payers to understand what the impact of the robotic modality was to the patients that they care for. And we established a sixth annual clinical symposium that was dedicated for robotic surgery. We worked very closely with Intuitive Surgical so that the payers had the opportunity to come to this event, sit on the consoles. We're able to use SimNow for a augmented reality hernia procedure, which we felt was a hit at this symposium. And it really allowed us to foster a conversation and a dialogue with respect to what we're seeing with the quality outcomes data as it relates to the robotic modality. And here are three of the different IRBs that we've submitted with respect to our research initiatives within Northwell Health. Now, I want to talk a little bit about the operations, because what exactly does that entail with respect to how we're going to grow our program? Initially, we did not have any types of really marketing collateral at all, let alone a robotic website. So we had the opportunity to partner with our corporate marketing team to create a robotic website. And one unique aspect of the website is for the ability of patients to contact myself and my clinical counterpart directly, should they have an inquiry about robotic surgery, whether it's, does the robot do the procedure, or I have a complex incisional hernia, I'd like to be placed with a robotic surgeon within Northwell Health. And that call to action really allows for my clinical counterpart and myself to place the patient with the most appropriate robotic surgeon. We spent a lot of time on instrumentation standardization, and we'll kind of go through in detail in a subsequent slide exactly what that looks like at one of our pilot sites. We developed a pathway for new surgeon success. So what we really wanted to do was invest in our surgeons and ensure that they are given and afforded all of the opportunities to really be an all-in robotic surgeon. We created a moonlighting pool. We evaluated the first assistant role within our organization. We evaluated requests for newer incremental systems. So anytime we bring a new incremental system into either an existing robotic surgery facility or one that is going to be a de novo, we really try to be thoughtful about it and very strategic in whether or not we were going to place one there. And we really focused in on the financial impact, the facility impact, the conversion impact, and the market share analysis. Not one of our incremental systems was placed within Northwell Health without having a business plan attached to it and a strategy on how we're going to grow the volume there. We began publication of our newsletters. We send them out on a quarterly basis. This goes to our entire perioperative staff, hospital leadership, clinical leads, executive leadership, just so it's an ability for us to communicate on all of the wonderful things that we've been able to accomplish as a system committee. One of the things we've done recently, we've established, obviously, the System Robotic Committee, but recently we wanted to develop a OR leadership meeting. So this meeting, not dissimilar to our System Robotic Committee, meets on a regular basis. And who is participating? It's essentially the first assistants as well as the perioperative leads from each one of our facilities. We are very big on standardization and best practices. And we wanted the opportunity of our system perioperative team to hear others within our organization that have very successful robotic programs and really look introspectively, understand what we do really well as an individual institution and how can we leverage our partners at our other hospitals to really implement best practices standardized throughout their hospital. And that's a very critical piece that you'll hear a number of times throughout this presentation is really the importance of standardization. So I mentioned before the website. So we developed the website. We got a nice little a phone number assigned to it, 844-ROBOT-MD. And what I highlighted here is really the call to action with respect to trying to align patient need with appropriate clinical care. I talked a little bit about tray standardization throughout the health system. This is just one example of one of our large tertiary sites and what we were able to do by thoughtfully evaluating the robotic tray, the laparoscopic tray, and the soft tissue tray within our organization. And what we were able to find is that, after scrutiny of what's currently included, what can we remove? Now, from the robotic tray, there wasn't anything that we found that we could safely pull from the tray. From the laparoscopic tray, we were able to reduce the amount of instrumentation from 23 to 15. And the soft tissue tray was really the biggest impact that we had as a committee by evaluating what's included in there. We were able to reduce the instrument count from 106 to 45. It's a variance of 61. So overall, we reduced our lean instrument tray from 146 instruments down to 77, which is a tremendous accomplishment. And this is just one facility. We completed this exercise at every single facility within Northwell Health that had a robot with similar results. It's really about just being thoughtful of what is truly needed throughout a robotic case. One specific specialty focus that we had was on our hernia surgeons and how we can look at the trays that are currently used for our hernia procedures throughout Northwell Health and really reduce them and pare them down to an appropriate level. Now, one of the reasons why we chose hernias is, as you're probably aware within your facilities, with the advent of the X-size system, it really afforded our general surgeons to find a foothold using the robotic technology. And we focused on hernia because in our organization, it was the fastest growing specialty. So by looking at all of the current instrumentation usage and critical operative steps that is currently used, regardless of what facility is performing the hernia procedure, we very thoughtfully brought all of the hernia surgeons together and just had a good conversation around what are our critical operative steps, what is the instrumentation that's used, and how can we pare that down? How can we become more lean and more efficient within our organization? So Intuitive was kind enough to put us together a couple of different slides on volume, average console time, and average INA cost. And you can see for both ventral and inguinal hernia, not only was volume going up from 2018 to 2019, console time was going down, and INA cost was also going down. And I think this could really be attributed to our collaborative approach with our hernia surgeons to really evaluate, as I mentioned, one, the critical operative steps, but also what's being used throughout that procedure. Now, I mentioned before that we really wanted to, in collaboration with Intuitive Surgical, develop and deploy a pathway for new robotic surgeons to ensure a seamless and successful adoption of the modality. So we really put it into 5 different phases. The first being we really wanted to differentiate between our interested and our committed surgeons, because there is a very large distinction between the two. In phase 2, we wanted to introduce the technology and the procedural techniques to these physicians. Then phase 3 is their practical training course. And what we've been able to do at Northwell is create a robotic training and simulation lab at our Bioskills education and training facility, where we are now offering certain practical training courses to be performed there. But personally, I think that there's a lot of value in attending a Intuitive-led session at one of their sites, and we worked with Intuitive to get those physicians time at their sites or at our Bioskills to be trained from a practical training standpoint. Then we put together an initial case series. Work collaboratively with the surgeon on what that should look like. And then phase 5 is continued development and quality outcomes and operational overview. Really think thoughtfully, evaluate every case that's performed robotically, and be thoughtful about different approaches or different techniques that you could use to really ensure success as you move forward as a very competent all-in robotic surgeon. And this is just the impact that going through these phases really had with one of our surgeons. This surgeon in particular really hit the ground running, bought into this surgeon pathway, and within 1 year had performed over 100 cases. And you could see the reduction in time as well as the growth over the months for this particular surgeon, who I think was a really great candidate to bring through our new surgeon pathway, because we were able to upfront differentiate, like I said, between interested and committed surgeons. One other focus within Northwell Health is we really appreciate the importance of a dedicated first assistant to really help facilitate the throughput and the operations of their program. And we did this study very early on, the impact of a dedicated first assist on our overall room in to room out times. And we did a comparison of two surgeons, one GYN oncologist and one urologist. And we looked at the impact that the FA had relative to that of the resident that would come into the room and support the case. And when the first assist was there was a significant reduction in the overall time. For the GYN oncologist, about 29 minutes, and for the urologist, about 25 minutes. And another very important component of having a dedicated first assist is you really then allow for the resident to be trained, to sit on the second console, to understand what critical operative steps the surgeon is taking, why they're taking it. It allowed for our residents to really learn and allowed for our first assist to be focused on programmatic growth, be focused on efficiency, and be focused on turning that room over. And one other thing of note is every incremental system that we bring into Northwell Health is really attached with a dedicated FTE that we would like to see the program be facilitated by a first assist. And not only just do the typical functions of a first assistant, but also to look at the program effectively, understand where there's potential to possibly move a laparoscopic case to the robotic room, and such. I mentioned the newsletter. This goes out once a quarter to all of our executives, our clinical leadership, and our operational team. Now, I mentioned when we bring on a new technology or new system to either an existing site or a de novo site, we really are very thoughtful in what we're doing in terms of assessing the ability for us to create a program that will have long-term success. And a lot of that is predicated upon incremental volume. I mentioned that every place system comes with a specific market share analysis where we hope to really leverage the technology and the new innovation to drive patients into our facilities. We look at who are the new robotic surgeons that are going to be performing the procedures. We like to assess what leakage there perhaps is because a surgeon might not be getting the access to the technology that they would like and therefore take it to a competitor. We look at the impact to laparoscopic and open conversion to robotic and what that means from a financial standpoint. We assess the payer mix of those patients that we're looking to target. And we really are very thoughtful around, is our growth on the inpatient side or is it on the outpatient side? We look at the facility considerations. Has the site identified an OR? Have they identified the staff that's going to support this robotic room? And before any system is placed, we do a systems readiness check along with our partners at Intuitive Surgical. We look at cost assumptions, anticipated supply cost, acquisition expense, incremental cost for doing lap procedures on the robot, increased OR time. And as I mentioned, the additional FTE for the first assistant program manager at that facility. And then we look at cost avoidance. We look at the days saved by having the procedure or the patient receive their surgical intervention through the robotic modality. We look at the lap shift supply savings. We look at maintenance savings. We look at instrumentation rebates. While considering all four of these very specific areas, this is what goes into what we consider to be a very comprehensive look around the vitality and the potential success of placing the new robotic surgical system at, like I said, either the site that already has a program or a de novo location. Now, lastly, and one that I'm most proud of, is our foundational pillar of education. Our committee's focus was really around securing an investment so that we can build out a robotic training and simulation center at our Bioskills Education and Training Lab. We focused on developing curriculum collaboratively with our clinical system leads as well as Intuitive Surgical. What we didn't want to do is reinvent the wheel, and Intuitive is that expert resource to really guide us with respect to what we're developing in terms of content. And we didn't want to limit this just to practical training for surgeons. We knew the importance behind having a seamless approach, seamless team approach between the first assistant, the OR team, the residents. We looked at, obviously, as I mentioned, the practical training courses, as well as the development of advanced training courses. Our entire goal was standardization. What we wanted was, if you are a FA or an OR team member at a facility in Eastern Long Island, we wanted you to be trained the same as whether you were in Westchester. And that's important to establish those high important quality outcome indicators that we felt were necessary and could be impacted by the training. So having our teams trained appropriately was paramount to really establishing our education and training center at Bioskills. We were able to leverage internal training courses to teach optimal instrumentation use. We secured CME credits for the courses that we've established here in Northwell Health. And most recently, we developed a universal residency curriculum that either our urologists, our GYN residents, or our general surgery residents, they're using a central core curriculum. Obviously, they're modified for their specialties procedures, but the core of the curriculum is standardized throughout the system. Now, we opened our Bioskills Robotic Education and Training Center in August of 2019. Now, we've trained about 149 employees at our Bioskills Training and Education Center. Our first robotic workshop for first assistants were held in August of 2019, and our first attending level cadaveric training was held in August of 2019. And one of the really cool things that we did with that cadaveric training is we augmented that training session with development of a 3D printed model to augment that training process. This is just an example of the curriculum that was established collaboratively with Intuitive Surgical with respect to our FA trainings. I mentioned before the robotic residency training pathway. This was a lot of effort by our residency program directors of all the specialties coming together and understanding what are the milestones that are necessary and critical to build into the existing residency curriculums to really support our robotic residents, the ones that are very interested in the robotic modality. So from a content perspective, that is it. But some of the primary takeaways that I hope that this group got out of this conversation was really the importance behind establishing a dedicated committee to overseeing all facets of the robotics program. One thing that I would strongly suggest is having a dedicated administrative resource like myself that can act as the bridge between Intuitive Surgical. And one of the important things there is Intuitive Surgical recognized the importance of this as well and really invested in an individual to be my counterpart from Intuitive Surgical that could help all of these initiatives really be pushed through as quickly as possible. I strongly urge you to determine what your pillars are. I argue to use data to help drive strategic decisions. Standardization is key. Communication and alignment between clinical and administrative leaders is paramount. And always continue to innovate. Always ask the question, what can we do better?
Thank you, Frank, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions that you have by typing them into the Q&A box that you see on your dashboard. All right, Frank, I'm going to start with where you left off with primary takeaways. So your first takeaway was around steering committees. Clearly, with such an expansive program, the question is, how do you execute robotic steering committee meetings at Northwell? How often are the meetings held? Are they system-wide versus site-specific? Who is present at those meetings? And what does a normal agenda look like? I know this is a bit of a catch-all question around robotic steering committee meetings, but we'd love to get your perspective on them.
It's not necessarily a simple answer, obviously, given the geography that we're covering within Northwell Health. We've established a system committee meeting. That meeting takes place on a quarterly basis, but I had mentioned our pillars. So every other month, we have all of our robotic surgeons come together for an agenda, and that is typically focused on one of the pillars. Some months we discuss credentialing and credentialing alone, as it was the case when we first formed as a committee. Other meetings will separate between operations or education. It's really dependent on what are the primary objectives of the committee at that individual time. Now, I said it was a little complicated because at the local institution, we allow for the autonomy to really take place there. So although there's representation from a system committee perspective, from a clinician joining our system committee, there are other robotic surgeons at those facilities that we expect should be meeting on a quarterly basis at a robotic PICG. And one of the things that we did right away was we found there was so much variability between what's discussed at these local institutions. And we spent some time thinking about, well, what should they really be discussing? And we put it into essentially 5 buckets. So we wanted to have every PICG centered around quality. We wanted a review of complications, a review of readmissions, a review of mortality, a review of return to OR. And in that regard, we've partnered very closely with a lot of the local institutions to provide them with that data. So prior to their PICGs, we'll work to get the perioperative leads and the clinical leads of these institutions, all of the complications that occurred within their facility, all of the readmissions, all mortality, all return to OR. And the expectation is that they go back and evaluate the clinical records what exactly went on. We expect them to discuss operations, turnover, instrumentation, staffing, delays, block time. We want them to develop improvement strategies. Another item is always going to be credentialing. Who are the newly credentialed robotic surgeons at your institution? And then any site-specific updates we leave to them to kind of formulate, additional agenda items through there.
One question that I think is a hot one is around your involvement in the surgeon training pathways. I think you mentioned interested versus committed surgeons. When do you involve yourself? Why do you involve yourself? Additionally, what value have you observed because of your involvement in the surgeon training pathway?
Well, I think that that particular question is one that I can really demonstrate the successful partnership between Intuitive Surgical and Northwell Health. And what I mean by that is we've really had the opportunity to partner very closely. So, typically the first person to find out if there's an interested surgeon that wants to pursue the modality, it's going to be Intuitive. That does not mitigate other surgeons from contacting us directly or their chairs, but that just naturally seems to be who knows which surgeons are very interested. So typically from there, we would sit down collaboratively with that surgeon, understand exactly what their expectation for training is. And we establish some of the guidelines that I went through before in terms of the phases, differentiate between interested and committed surgeons, introduction to the technology, coordinating practical training courses, planning out an initial case series, and lastly, really a continued development and quality operational overview.
I think we have time for one more question. I think this is a great question to end on. Clearly, Northwell Health has accomplished so much in such a short amount of time. We want to know what's next. Clearly, you are not done. So what are some of the areas of focus in the next chapter of robotics for Northwell Health?
Well, as I mentioned in an earlier slide, continue to innovate. What can we do better? And some of the areas that particularly myself and some of the other surgeons is leveraging technology to help push us to that next phase, whether it be the development of application that's all of our robotic surgeons can access and, leveraging in-touch technology, some of the suite of offerings that Intuitive Surgical has, the development of a case library, understanding what are the lean instrumentation profiles, having that reside in one central resource so that regardless of whether you're a proficient robotic surgeon or one that's interested, you have the ability to access through this application everything about our program, our policies, our credentialing pathways. You have the opportunity to look at what surgeons do really well, what lean instrumentation profile is. So really, it's about leveraging technology to help advance our quality and our patient experience within Northwell Health.
That is all the time we have for today. I want to thank Frank again for his excellent presentation and Intuitive for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.